Greetings, Professor and classmates. Welcome to our Concussion PowerPoint created by Elizabeth, John, and Nick. The purpose of this PowerPoint will be to give you all an overview about the pathophysiology, clinical manifestations, and management of concussion patients. Hope you all enjoy and learn something. Now let us begin. Traumatic brain injury may occur at any age or disease state, but peaks between the ages of 15 to 24. Traumatic brain injury occurs 3 to 4 times more in males and is more common among those that play contact sports such as wrestling, football, and soccer. Overall, 50% of traumatic brain injuries occur from motor vehicle accidents. However, in individuals over 60 and under the age of 5, the most common cause of traumatic brain injuries are from falls. These types of brain injuries include contusions, diffuse axonal injuries of various levels, contusions, and cerebral hemorrhages. A concussion is a form of mild traumatic brain injury and therefore is the result of head trauma. It is a type of mild diffuse axonal injury. There is no permanent structural damage, and the presenting symptoms are temporary and reversible. Traumatic brain injury causes a release of excitatory neurotransmitters such as glutamate, and an abnormal release of potassium from cerebral cells, and the influx of calcium into these cells. This causes neuronal depolarization. In an attempt to restore ion balance, membrane pumps which require energy are activated. This therefore means that there is an increased glucose need to these areas. Following this, overexcitement of neuronal activity is a period of underexcitement. This can be seen as temporary memory loss, confusion, and/or amnesia. There are 4 grades of concussion. Each are differentiated by their symptoms and the severity of these symptoms. In grade 1, symptoms last less than 15 minutes and there is no loss of consciousness. In grade 2, symptoms last more than 15 minutes, yet there is still no loss of consciousness. In grade 3, there is a loss of consciousness lasting from seconds to minutes, accompanied by noticeable brain function changes in areas such as the motor and cognitive fields. In grade 4 concussion, there also is a loss of consciousness, lasting from minutes to hours, in rare cases even up to 24 hours, that are also accompanied by noticeable brain function changes such as in the fields of motor and cognitive fields, plus there may also be vital sign abnormalities. These vital sign abnormalities may show up as apnea or EKG changes, typically lasting less than 30 seconds, and they self-resolve.
The relevant history that poses an increased risk for concussion include patient at high risk for falls, contact sports and activities, substance and alcohol abuse, child abuse and domestic violence, history of a recent concussion. Patient falls are the most common type of inpatient accident, with approximately 1 million inpatient falls occurring in the United States each year. The very young and very old are commonly have the highest risk for falling. Muscle weakness, agitation and confusion, urinary incontinence and frequency, postural hypertension, and certain medications such as benzodiazepines and opioids are among the other risks for falls that can result for the patient in suffering a concussion. Participation in sports is at an all-time high. Athletes of any age are at risk for concussion. Concussion risk increases depending on the speed of movement and intensity of physical contact. The sports that are at the highest concussion risk include football, soccer, ice hockey, rugby, and lacrosse. According to CDC, approximately 300,000 head injuries were reported each year among high schoolers. Among these reports, 90% are concussions. These account to 270,000 cases, which only covers the high school age group. Most of the people who have substance and alcohol abuse suffer from traumatic brain injury after use. This is due to its effect of the altered of the level of consciousness and awareness of a person. It doesn't only increase the risk of suffering from a concussion, but also affects the treatments as medication may vary due to substance abuse. Finally, domestic violence or other encounters between people living in the same household increases the incidence of concussions. People of different economic, cultural, and educational backgrounds are also affected. It often comes with a variety of factors such as substance abuse, poverty, and etc. Here are the pathophysiological clinical signs and symptoms. After a concussion, the client may experience a brief lapse of consciousness with temporary disorientation, headache, blurred or double vision, emotional irritability, dizziness, nausea, lethargy, difficulties focusing, and irritability to bright lights or loud noises. The patient also suffers from amnesia or memory loss. It could be retrograde or anterograde amnesia. Retrograde amnesia is a form of amnesia where someone is unable to recall events that occurred before the injury, even though they may be able to encode and memorize new things that occur after the onset of the injury. On the other hand, anterograde amnesia is a loss of the ability to create new memories, leading to partial or complete inability to recall the recent past, even though long-term memories from before the injury remain intact. Sufferers may therefore repeat comments or questions several times, or fail to recognize people they met just minutes before. Post-concussion syndrome happens after a few days. Headache, dizziness, irritability, emotional liability, lethargy, sleep disturbance, decreased attention, judgment, concentration, and memory abilities may continue for several weeks or months. Post-concussion syndrome alters a person's ability to resume normal activities. Stress and psychological trauma is said to be the contributing factor to its presence and severity.
For the management of concussions, on initial examination, the provider will assess the mental and neurological status of the patient when first assessed. The Glasgow Coma Scale should be used to receive a baseline status of the patient. If the patient deteriorates, alternative diagnoses should be considered. But if the patient continues to regain consciousness preceding the event of the incident, the diagnosis of a concussion would be appropriate. In mild cases, a assessment on mental clarity, weakness, and ocular abnormalities, and a Babinski sign should be assessed. For the treatment and management of concussion, essentially there are no pharmacological treatments in managing minor head injuries. However, if the patient has persistent head pain, then a non-narcotic analgesic is recommended for the head pain, such as acetaminophen. Since narcotics may affect the level of consciousness, they would interfere with the ongoing provider assessment of the patient, since we will be ruling out cerebral injuries that may present themselves with a sudden altered level of consciousness. NSAIDs such as Motrin should be avoided, since in the event of an intracranial hemorrhage, it would alter the coagulability of the blood, promoting the bleed. As far as radiological studies are concerned, an X-ray should be obtained at the site of the injury to ensure that there are no skull fractures that may have resulted from the concussion. A CT scan should be obtained to rule out the post-traumatic intracranial hemorrhage in patients. Risk factors for intracranial hemorrhage are patients who are less than 16 years of age or older than 65 years of age as well. Patients who take anticoagulants such as aspirin or Plavix are also considered to be at high risk. Patients with a prolonged level of consciousness lasting longer than a minute, severe persistent vomiting, focal neurological signs, and seizures are all signs that a hemorrhage may be taking place. With management, observation of the patient is key to ensure that there are no neurological deficits that arise from the incident. especially when there is a prolonged loss of consciousness in the patient at the time of the incident. One should also monitor for delayed signs of subdural and epidural hemorrhage and intracerebral bleeding. Clinical manifestations such as worsening ALOC or unilateral paralysis may be signs of these conditions. In addition, sometimes there may be transient amnesia, paraplegia, and blindness after a head injury, and these all should be monitored as they could indicate a worsening condition. There are quite a few complications that arise secondary to a concussion. A few of these complications are seizures, autonomic dysfunction, hemorrhages, extrapyramidal symptoms, and hydrocephalus. Seizures are considered to be one of the most common delayed complications from cerebral trauma. Approximately 5% of patients with closed head injuries and 50% of people who sustained a compound skull fracture will suffer from post-traumatic epilepsy. The risk of epilepsy has been said to be greater in the presence of parietal and posterior frontal lesions. Recommendations for the treatment of seizures are the use of anti-epileptic drugs to prevent subsequent seizures after the incident. Medications such as Dilantin have been found to be effective in treating epilepsy secondary to cerebral trauma. Autonomic dysfunction, also known as storm syndrome, is a serious complication that can result from a severe head injury. It is a syndrome of episodic clinical manifestations that include a vigorous extensor posturing, diaphoresis, tachycardia, and hypertension, all of these symptoms lasting a few hours. The manifestations are the result of excessive sympathetic activity and often arise spontaneously. Benzodiazepine agents are known to be effective in treating this syndrome. In regards to hemorrhaging, CT scanning of the cranium are one of the essential therapies to rule out any intracranial hemorrhages. And we want to ensure that we eliminate any possibility of cerebral trauma such as a sizable epidural, subdural, or intracerebral clot or hemorrhage, which would be an indication for immediate surgery. Over the years, there has been controversy regarding the relationship between extrapyramidal disorders and the relationship with cerebral trauma. There have been cases confirmed that have led to extrapyramidal symptoms following injury by a study done by Harris et al. In 2013, which demonstrates the conclusive evidence of Parkinson's following a head injury several weeks after the incident. In such cases, a neurological consultation should be recommended for follow-up. Finally, post-traumatic hydrocephalus, which is an abnormal accumulation of cerebrospinal fluid that enters the brain as a result of an injury, is also a complication of concussions. Clinical manifestations of hydrocephalus include headaches, vomiting, confusion, and drowsiness. If suspected, it is very important to monitor intracranial pressure as well as do a neurological consult to see if surgery is indicated, as usually these are treated with a ventriculoperitoneal shunt.